So a lot of what we did on Friday was a review of the last two tests. So I'm not going to review the review, but we are going to kind of review the the terminology and the things that we talked about that we're going to talk about in this section. So we started with just kind of an overview and what it is that causes scatter radiation and how then we clean that scatter radiation up. Let's see how this came in. Good. Right, so we talk about, as we've talked about earlier in the semester, technical factors effect on scatter, beam restriction and its effect on scatter. Keeping in mind that anything that causes exposure to the patient in beam size, be it thickness or the size, the area of collimation, changes the amount of scatter created. So then we talk about patient factors, things that you have very limited control over, or we will talk about, and then post-patient scatter removal, which is essentially grids and air gap technique. There is another option, that's what we refer to as a post-patient collimator, but you don't really see that in diagnostic all that much. I'll tell you where you might possibly run into that. So we talked about the difference between the primary beam, that's before it interacts with the patient, the remnant beam, that's what comes through the patient. We talked about the types of interactions and the types of interactions that we would want idealistically would just be our photoelectrics and our transmission, but we also have those transmitted scattered photons in both Thomson and Compton. Thomson aren't really an issue, but Comptons are. So Thomson's very small percentage of the beam, and they just kind of look like penetrated X-ray photons. Again, technical factors, we've done that. The difference between what we're doing now and what we were doing before was the difference between sharpness of reported detail, that's the lines, and visibility of reported detail, and that's whether or not we can see those lines and the difference between the densities between adjacent structures. So we talked about that. We talked about the methods to control scatter. That was pre-patient and post-patient. Pre-patient would be your your beam factors. That would be your KVP and your average energy. So there is a little bit of difference in scatter radiation between single-phase, three-phase equipment, highly filtered equipment. There's some differences whenever we have an increase in inherent filtration, and I'll relate a story to that eventually. So then we talked about, and we'll get into methods of scatter control post-patient. That would be grids and air gap. The terminology was contrast, density difference, contrast resolution is just that. Again, on test questions, you might look at a question that's asking you about resolution, and the immediate thought in your mind is going to be, is this contrast or is this spatial resolution? Almost always the question will be specific to difference, and one of the answers will be contrast resolution, or the question will reference contrast resolution and the answer will be like difference in densities. All right, so contrast resolution is going to show up in there if it's contrast resolution, right? That's not to say that I might not ask a question about spatial resolution and put contrast resolution as a possible answer. That's a possibility. But if it's a question about contrast resolution, it's going to say difference, difference in density. It's going to say contrast resolution as opposed to just resolution. If it just says resolution in the question, that is spatial resolution. Okay, sharpness of actual reported detail. So again, we reviewed grayscale and latitude, and those are essentially the same thing and opposite of contrast. Again, primary, remnant beam, field size, and collimation are really referring to the same thing, but they're inversely related as well. A larger field size means less collimation, smaller field size means increased collimation. So I've described what positive beam limitation is, and that is automatic collimation. It just doesn't really apply anymore. I told you why I think that it should. And this is, oh, I didn't save it, okay. I'll try to upload was working on this and I added an image. Anyway, it was yet another shoulder where they included the entire lung, the half of the spine, and almost the entire humerus. Positive beam limitation would prevent you from doing that. It would focus is a bad word, but it will limit the radiation to the area of interest. So we talked about grids, or we talked about what grids are, and I brought a couple of examples of those, and we're going to talk about them in depth. Grid ratio, grid frequency are measures both of the effectiveness of the grid, and we'll dial that in a little bit tighter later on, and they are for scatter cleanup, a scatter that's already been created post-patient. We talked about contrast improvement factor just being a reference to how much contrast you have with a grid versus how much contrast you have without it because of that cleanup of the scatter radiation. The Bucky factor is a mathematical compensation, mathematical equation for compensation for grid use. So we'll talk about that deeper in the semester, or in this chapter. Grid cutoff, we'll describe the different types of grid cutoff. That is where we can actually visualize grid lines, and it decreases the density and not in a good way. Grids, if used properly, will decrease, exposure. It decreases exposure, but not in a good way. Grids are going to decrease exposure, and that's why we have a Bucky factor to compensate for that. But grid cutoff does it in a bad way, and we'll talk about that. So again, patient dose with grid use, ear gap technique will define those. Remnant beam, again, noise is just the definition of noise is any random fluctuation of density across the image. So the two types of noise would be quantum model, which we dealt with, and that's always a shortage of mass, and fog, right? So fog is scatter radiation, so that's where it's applicable in this section. So scatter radiation is any unwanted exposure on the image receptor, and it lays down a layer of density. I'll tell you the things to watch for on a test, and how you're going to have a tendency to kind of twist unwanted density into something that it's not. Beam limiting devices are going to be, again, your collimators. We talked about two sets of collimators, one on top and one on bottom. The ones on top were specific for limiting off-focus radiation. The ones on bottom are the shutters that you actually see whenever you collimate, you open and close your collimation. Those are the ones that limit your light field and therefore limit your radiation field. All right, so we talked about interactions in the tube, mainly create heat, but we do get a few x-rays out of it, a little bit of light. Brims and characteristic. Brims is because of the slowing down of the electron as it passes the nucleus. Characteristic is where you get the ejection of an inner shell electron and the creation of an x-ray because of the replacement of that inner shell electron. So factors affecting the emission spectrum pretty much are going to be the things we talked about for the first test: your KVP, your mass, your filtration, and your machine phase. Target material as well. So then the effects of the factors on the image. Mass was a direct relationship in every way. Double your mass, you double your exposure. Half your mass, half your exposure. KVP is also directly related, but it goes in a direct relationship, as in you increase, but it's exponential. You increase your KVP by 15%, and your image receptor exposure goes up by 100%. So SID is also exponential, but it's an inverse relationship. You double your distance and your image receptor exposure goes down by a factor of 4. So of all those factors, KVP is the most significant, SID is second, mass is a distant third. So things that affect the the focal spot size, and therefore your sharpness of recorded detail, where the filament, the angle of the anode, and our off-focus radiation gives us a increased focal spot size and decreases our sharpness of recorded detail. So I know I said I wasn't going to review all that, and here I am. So I'm going to try to stop there and go to new material. So we looked at images for fog versus no fog. The fog, remember, just covers up the sharpness of recorded detail, and that's why we call, you know, the ability to see your sharpness, visibility of recorded detail, right? So the sharpness is still there. We used a couple of analogies. You're driving down the road on a foggy day. You know, if you drive down the road on a bright sunny day, you can see the trees and everything, but the fog on a foggy day doesn't remove the trees, it just covers them up so you can't see them real well, right? Same thing on the X-ray image. If we have excessive fog, then we can't see the sharpness. We can't see the things that are actually recorded there. They're just covered up. So sharpness of recorded detail versus visibility. Sharpness are the lines present? Visibility, can you see those lines? Right? So scatter, factors affected scatter. We went through a lot of stuff, didn't we? And I think that's where we ended up. So still just more information from previous chapters. As KVP goes up, numbers increase, and those numbers include emitted unattenuated photons, but also the scattered photons, which are partially absorbed. So they are attenuated, but they still penetrate through the patient. So they go into the formation of the image and the calculation of your, you know, your S number, and then those numbers are applied to your lookup table to create your image. So if you have an image that's dominated by scatter radiation can still affect your visibility of recorded detail. Right? So just a reminder, as KVP increases, what we get is a change in frequency and wavelength. Remember, frequency and wavelength are inversely proportional. So as frequency goes up, then wavelength goes down. As wavelength goes up, frequency goes down. Everything travels at the speed of light, so naturally a longer wave is going to take a longer time to pass a point than, you know, a whole bunch of little bitty short waves. So as KVP goes up, remember that the percentage of Comptons that we create is, you know, they change a little bit, but it's not significant. What we really get is the percentage of the Comptons that are transmitted through the patient. And for that reason, we want to make sure that our KVP level is appropriate for the anatomy that we shoot, right? Does that have a major effect on, you know, thin anatomy where you don't create a whole lot of scatter radiation to penetrate, like extremity work? The answer is no, not really. You're not creating a whole lot of scatter radiation in those because they're thin, right? But you can over-penetrate, so you still don't want to use too high a KVP. So what we get with attenuation is either complete absorption in your photoelectrics, or you get a partial absorption in your scatter radiation. So a photon strikes an atom and loses some energy, goes off in a different direction. Since it lost energy, it's partially absorbed, right? So absorption just in this sense means a loss of energy. Okay, so you can have total absorption, which is total loss of energy of the X-ray photon, and therefore it's full dose to the patient, right? So, you know, you shoot just a chest X-ray with, as if you could get this 1 kVp. What are you going to have on the image? Nothing, right? Nothing's getting through the patient at that energy level. So it's total absorption. You shoot a chest X-ray at 120 kVp, you're going to get some penetration, you're going to get some exposure on the image receptor. Some of that exposure is going to be scatter radiation, partial absorption. Some is going to be straight penetration. So generally speaking, this is just in general, make sure that whenever you read your question, you read it very, and understand the specifics of it. Generally speaking, when we say as KVP goes up, your answer is going to be, as it relates to scatter radiation, scatter goes up, right? So know that that's not entirely true in context. It's still true, but it's minimally true, right? But just understand that what really the question is asking you in the context of the question is, as KVP goes up, the penetrated scatter photons increase much more, and therefore your image is dominated more by Compton than what it is penetration and photoelectric absorption. And that's what we refer to as the PE ratio. All right, so as KVP goes up, Comptons go up, and the context of that is they go up and strike, emit from the patient and strike the image receptor. Right. Photoelectrics are the largest contributor to patient dose. That's because it's total absorption. The entire energy of a photon gets absorbed inside of the patient. So, the whole dose goes up in that case. So, if we want to reduce dose, then we can increase KVP and reduce opacity. KVP, better quality beam, have more penetration. All interactions decrease, but we have fewer photoelectrics, and unfortunately a higher percentage of scatter reaches the image receptor. So we talked about this on Friday. Probably the thing that's going to affect the contrast on your image is the thickness of the body part that you're going to shoot, right? So the traditional the traditional rule of thumb for patient size was, or part thickness was, not to increase KVP, but to increase mass. Because as you increase KVP, you increase the scatter towards the image receptor. So if you increase KVP in a structure that already creates a lot of scatter radiation, soft tissue, then you've got soft tissue and high KVP both creating more scatter radiation that would emit from the patient. And therefore you have a compounded difficulty, right? So you've got scatter on scatter reducing contrast. Since your computer algorithm is the main thing that controls your contrast now, your radiographic contrast, scatter doesn't affect it as much, it's okay to bump your KVP a little bit. Realistically, historically, everybody bumped their KVP when they had a larger patient anyway. You have an asthenic patient, they would shoot with 1 KVP, but minimal change for a high percentage patient, might have been a 5 KVP change. But just know that as you increase the thickness of the tissue, you increase KVP, you're going to increase scatter radiation. It's going to be an exponential change. So we prefer to increase mass. The problem with that is the dose increases. We can't compensate for patient thickness with KVP, but scatter increases as well. And I beat this to death, but your computer algorithm is what controls your contrast. So that little bit of a change in KVP is really not going to do all that much. There are hardliners on that topic. I'm not quite a hardliner, but I'm pretty close to it. I really think we should be using KVP more for pathology changes, patient size changes, things like that. And I think we should be using higher KVP across the board than what we do, just to reduce patient dose. All right, so effects of KVP changes on the image, contrast, and density, really not much because your lookup table controls that. Visibility, recorded detail, well, that is your contrast resolution. So it's still not going to change it much. So your exposure, your index number, if you're using the 15% rule, or if you're phototiming, when you increase your KVP, what's going to happen automatically with your mass? Phototiming, you increase KVP. Mass goes down, right? So your AECs get to that exposure quicker, and therefore you have a lower mass value. It basically applies a 15% rule. So there's really no effect on the image receptor exposure. All right, so increased KVP, more x-rays are produced. If that's the only thing that we do, we change our KVP, then we increase the number that we produce. And then we emit more, so we have fewer that are actually absorbed. However, because we have more, the ones that are scattered are more likely to penetrate through the patient, then we have more scatter emitted from the patient. So percentage of Compton's increases, percentage of PEs decrease, and what we call that is the Compton to PE ratio. Our overall scatter to the image receptor increases, and our contrast really ain't going to decrease. It's not going to be visible, even though it says contrast decreases. That really should be edited out. So with mass, again, inside the tube, you got heat, you got numbers. The mass directly controls the number of electrons on the filament. That's really MA. Once you make your exposure, it controls the number of photons that go across from cathode to anode. That directly affects the number of X-ray photons that we create. So increased mass, increased electrons, increased photons in the beam, increased exposure to the patient, increased exposure through the patient to the image receptor. There are some potential sharpness issues. When we talked about those, if you use long exposure times, then the patient may move, right? And then we've got motion artifact. That's going to decrease sharpness of recorded detail. If you have long prep times, then we've got blooming. That's going to decrease sharpness of recorded detail. If you have to use large focal spot because you're using a large exposure, that's going to decrease sharpness of recorded detail. So those are kind of mass issues, and each one of those can have a deleterious effect on sharpness. All right, so when we change KVP and our mass, we still are going to change the percentage of scatter, but if we're using the 15% rule, the effects on the patient exposure are going to go down. Effects on the image receptor exposure are going to stay the same, essentially, right? Effects on sharpness of recorded detail, there should be none. If anything, you might improve sharpness of recorded detail if you increase KVP and reduce mass. You could potentially decrease sharpness of recorded detail if you went in the opposite direction with it, decrease KVP and increase mass. I can't think of a valid scenario where you would do that. And then effects on the patient exposure, it will go down. Effects on image receptor exposure will remain the same. So, we get to collimation. As we increase collimation, this is increased collimation over here, decreased collimation. As we increase collimation, we're going to limit the beam to what tissues we want to expose, right? So what was the original purpose for collimation? It's beam restriction. For what purpose?
Radiation protection.
Radiation dose, right. So it's radiation doses. Radiation dose, the dentist did that, right? So it's radiation dose. And for, I'd say, 100 years, it had a secondary effect on contrast, right? So it went from almost strictly, at its inception, strictly an ethical and moral issue to reduce the amount of radiation to the patient, to that plus affecting your contrast, because if you hit more tissue, you create more scatter radiation, reduce your contrast. And now it's really pretty much back to just a moral issue, right? So you reduce the amount of tissue that you expose. You're going through and you're almost done with radiobiology. What happens with increased dose? I mean, what is a likelihood of any kind of bad effects from exposure to radiation on dose?
Cancer.
As cancer, but is it more exposure gives you more or less chance of a bad effect? More, it's cumulative, right? So let's say you habitually overexpose a patient. You're shooting just for in this case, let's say that's the T-spine. Not the best example here because a lot of your radiologists and especially ER doctors want you to shoot the entire chest for T-spine for reasons that we'll talk about. But instead of collimating to the T-spine, you shoot the entire chest. Which one's getting more dose? Chest. Yeah, you do this every day for 6 months. Which one's getting really blasted and which one is more responsible for you to do? Collimate or not collimate? Collimate. It's collimate, yeah. All right, so collimation comes with a little bit of a caveat. You want to collimate to reduce the image receptor exposure. It doesn't really have that much of an effect on your contrast anymore, but it does affect the amount of tissue that you expose, right? Your contrast is primarily going to be your lookup table, but you are going to create more scatter radiation here. Scatter radiation, the image receptor has to deal with it. But the radiation dose to the patient is much greater if you don't collimate, right? So why collimate? Radiation dose. What is your job? We have an acronym for how much radiation we should expose the patient to. ALARA. What does that stand for? As low as reasonably achievable. Blasting every chest x-ray or every T-spine like a chest x-ray, is that keeping your dose as low as reasonably achievable? No? What are you training to be? Radiologic technologist. What is that? Two things really, imaging specialist, but also a patient care advocate. Which one of these two is better patient care? Right, collimation. So, can't stress it enough, if your hospital or doctor protocol is to take a chest x-ray for a T-spine, and it really should be in a trauma situation, then this is what you're gonna do, okay? That's not on you, all right? You're not gonna go to a radiologist and say, you're doing it, you're an idiot for doing it. No. In a trauma situation, the chest x-ray, I've talked about the golden hour before, right? Okay. So golden hour, every image that you take in the ER, providing you're taking any x-rays in the ER, takes up some of that golden hour, okay? So chest x-ray, then you collimate in, you shoot an APT spine, then you open your collimation, you shoot a KUB, then you collimate down, you shoot an APL spine, and then you do all your, you see where I'm going with this, right? You're wasting time. So in a trauma situation, chest x-ray becomes a T-spine. So there are times for this, right? If your patient comes in and you ask them, where are you hurting? And they're pointing to here. My back hurts. Well, where is it? It's kind of on the back side of this right here, right? When you T-spine, your collimated field should be smaller than that. So should you open up your collimation? Answer is yes, because this right here corresponds to more like this right here on the back side. So you probably should open your collimation up a little bit more. So there are times for it, but barring those circumstances, what you really need to do is to collimate in as tightly as possible. So that's caveat number one, hospital protocols and patient condition. The other thing is, if you over collimate and you eliminate anatomy that you should have included, what do you got to do? Yeah, what'd you say? Double your dose, exactly. It's not going to be exactly double because you collimated in so tightly the first time, but it's close enough. So if the purpose for collimation is reduce radiation dose, and you have to shoot the patient twice, did you accomplish your goal? No. The answer is no. Okay, so do it, but don't overdo it. All right. So beam restriction. So you restrict the area. What I want you to not lock into your mind is you're not focusing the X-ray beam. X-ray is not a laser. You can't focus it. It's beam restriction. It is not beam focus. Okay, and where you're going to have a kind of a struggle with this is that when the image comes up, you're going to make a leap from, well, if you actually collimated for a shoulder, down to shoulder size, well, we're focusing on the shoulder. Yes, you're focusing on the shoulder, but you didn't focus the x-ray beam. You blocked the x-ray beam from exposing other portions of the body. You didn't bend those x-ray photons to focus on that one spot. Does that make sense? Okay, so the other thing is also this. If you block this radiation, you collimate in, you see where all this scatter radiation is going, and the misrepresentation is that the scatter radiation is kind of following the divergence of the central ray, right? So divergence is coming down like this scatter radiation is created and it goes out at a wider angle. But that's a little bit of a misrepresentation. That photon could just as easily go this direction. Okay? So scattered photons will also go back in that direction. That's what we would refer to kind of sort of as backscatter radiation. It's it can go anywhere. It's like isotropic emission from the patient. It can go anywhere. Most likely to go towards the image receptor in any kind of trajectory. So now let's apply this photon that's created over here, and in this drawing is going out this way. What happens if it goes that way? Does it add to the image? The answer is yeah. So if we collimate in and collimate that photon off that will be created out here and hit the image receptor, what happens to our image receptor exposure? We eliminated some of those photons. So your image receptor goes down, yeah, it goes down. So that's the other thing. Sometimes I'm talking and you'll answer, and I don't read lips real well, and if I'm running my mouth, I can't hear y'all talk. So if I ask again, it's because I'm half deaf and I was talking at the same time. All right, so if, let's say, on this image, we shot this image and we got the perfect index number. Index number came, let's say the range was 200 to 400 for valid index number. You hit right on 300. Okay, right in the dead square middle of it on this image. And the radiologist said, okay, and let's say this is portable or something where you had to set a technique. The doctor said, okay, that looks good, but I want to get rid of some of that scattered radiation. I want you to collimate down just to the spine. So you go back in and you shoot to just the spine, and you don't change your exposure. You don't change KVP or mass. What's going to happen to your image receptor exposure? They kind of show it here. It's going to decrease. It's going to decrease. So what should you do once you collimate? You can test this out in clinicals too. What should you do when you collimate? Because you lose image receptor exposure. You had perfect exposure over here. Once you collimate, you lose image receptor exposure. To bring that image receptor exposure back up to that 300 mark, what should you do? Increase something. What should you increase? KVP or mass? I've done well in preaching KVP. Yeah, you probably should increase KVP, but no, for literature, you increase. Almost everything is an increase in mass. Okay, so your answer on the test is mass. Should you increase KVP? Probably so. But you're going to increase mass. Okay? And that's your answer on the test question. Increase collimation, increase mass so that you replace the photons that would be hitting under that T-spine. Okay? So how much of a mass increase are you gonna make? It really depends on how much collimation. I mean, if you collimate to here, it's going to be less than if you collimate to here. So I'm not going to ask you specifics. I'm going to ask you in general. What do you do? Increase collimation, increase mass. Okay, to compensate, to replace those photons. So collimation from an imaging standpoint, as far as the scatter radiation, cleaning up scatter radiation is probably less important than what it was before, but it's still very important for patient dose, and also it's very important for formulation of your index number. We looked at that shoulder from before. If you remember it, there was a lot of direct exposure to the image receptor, right above the shoulder, way out here. You remember looking at that? Okay, so what that tells your computer is that the patient received extremely high dose. So it can't tell that there's not a patient there. It just sees exposure to the image receptor that shouldn't be there, right? So it goes into the formulation of your index number, and your index number, even though you might have used the right technique, because it gets all that direct exposure to that portion of the image receptor, it's gonna think you overexposed the patient. Your index number is gonna come out, depending on the manufacturer, either too high or too low, right? So how might that affect your contrast and density? It might. How? Well, I don't know. It depends on on your system. But it can actually, in that case, affect your contrast and density. Overexposure and direct exposure to the image receptor can actually give you a change in your contrast and density and appearance of your image. So, collimation is important. Collimation to prevent direct exposure to the image receptor is important for imaging. Collimation to prevent overexposure to the patient is really your ethical obligation, right? So, do it. I think we just pretty much hit all of that, but just to run through it, the purposes are to limit the amount of tissue exposed and direct exposure to the image receptor. The more collimation you have, the less dose you have to the patient, and the image quality, really sharpness of recorded detail and visibility of recorded detail has no effect on sharpness. Maybe a little bit on visibility, especially if you give that direct exposure. Can mess up your contrast, but certainly it's exposure to the patient, exposure to the image receptor. Right? So fog just means unwanted density. And this is where you're gonna kind of flip density around. Okay, so fog is unwanted density. How to word this? It's a density present on the image receptor. So if you clean up the scatter, regardless of it's pre-patient through collimation, post-patient through grids, then you're removing some of that density, okay? So you remove some of that density, you get rid of it as unwanted exposure. Let's change that to exposure to the image receptor. You get rid of it, you have to replace it, you're replacing it with mass. All right, so, but it is an exposure, okay? So what sometimes I'll have students confuse is that, okay, it's an exposure to the image receptor, it's unwanted exposure, so if we get rid of it, we get a better exposure. Well, define better exposure. Does better exposure mean that you've got, an increase in exposure? The answer is no, your exposure went, decreased. It's bad exposure, you got rid of it, but you have to replace that exposure. You can't just leave it alone. You have to replace the exposure to the image receptor with good photons. You remove the bad, you introduce the good. It's kind of like an oil change. You drive your car for 5,000 miles, drain the oil, you got rid of the bad oil, you just drive away, right? For about a mile, right? You got to replace it with the good, okay? So get rid of the bad, introduce the good. So how we limit that, again, is with beam restriction, field size. That's your collimation. With collimators, and then, we have a number of different types of beam restrictors, collimators. We talked about the two, the multi-leaf on top, but that doesn't really have anything to do with scatter cleanup or limiting exposure field, right? The second set is what does that. So what we're talking about here are things besides the shutters. So you got different types of collimators. One type of collimator is what we refer to as an extension cone. Chances are you're not seeing these in clinicals because they just don't have that much of a use anymore. But one is what we refer to as an extension cone or extension cylinder. And what those are is if you look on your the bottom of your x-ray housing, some of them have this thing that's got a slot in it. So some of your x-ray housings, the collimator housing is completely flat, and some have this little ridge. And if you look at that ridge, there's a slot in that ridge. And with that slot, what you can do is you can slide a number of different things into it. You can slide different types of filters into it, like wedge filters, trough filters, things like that. Or you can slide cones and extension cylinders into it. And what cones and extension cylinders are they're kind of like three-dimensional collimators. So the extension cone, or the extension cylinder rather, is just circular from one end to the other, but it's you know, if it's collapsed, you'll see a little thumb screw. If you undo that thumb screw, it extends. That's why I say extension cylinder. And what we can do with that is take it and put it on the collimator housing, and then, like, let's say we're doing sinuses, we're getting into sinuses, we're doing sinuses. When we x-ray sinuses, the only thing our entire field just needs to include from the top of our frontal sinuses to the bottom of our maxillary sinuses, right? So we need a radiation field about that big, okay? So we can take that extension cylinder and extend it all the way back to the skin line on the patient. What you'll find in the fall, somebody will probably do an experiment on collimators. And what you'll find is collimators are not that hard to penetrate. You can close them completely, all the way, and make an exposure, and you'll still get an exposure on the image receptor. Okay, but if you've got this big heavy chunk of metal that extends all the way up to the patient's skull, you're not going to get just a whole lot outside of that. So anything outside of the projected radiation field is just created inside of the patient. Okay, so very, very effective collimators. If it's not three-dimensional, it's what we refer to as a diaphragm. And a diaphragm is what Rollins was using in dentistry back in the late 1800s, early 1900s. So if you have just a chunk of lead with a hole in it that you can mount on your collimator housing, that's a diaphragm. So our collimators are referred to as variable aperture diaphragms. The piece of lead with a hole in it is what we refer to as an aperture diaphragm. So aperture diaphragm just means that. It's a hole where that limits radiation. Variable aperture diaphragm means you can change it. So if on the test you see variable aperture diaphragm, what is that? It's a fancy name for your collimators, right? If it doesn't say variable, then it's something that slides on, you know, to your tube housing. So variable aperture diaphragm is your collimators. Just keep that in mind. So a cone is kind of like an extension cylinder, but the cone follows more closely the divergence of the central ray and gives you a larger radiation field. So up in 215, we've got some cones. I think they were used for something entirely different, but they kind of give you the same effect. If you ever want to stop in 215, I can kind of show you the stuff we have in our display cabinet up there. All right. I don't want to sound negative or anything, but usually, and we've only taken this number of students twice. And the first time by this point in the program, we were up in 215 because it could hold the number of students we had remaining. You know, And congratulations on everybody still being here second semester. Yeah, great job. But I can't show you, I can't, bring everything down. All right, so those are your types of beam restrictors. Other things inside of the collimator housing, we talked about this last semester. There's a mirror, and there's a light, and the light is offset. And if you remember, two things about the light in the mirror, well, really three things. The mirror provides some level of inherent filtration, right? But the mirror is mounted on a perfect 45-degree angle, and the light is off to the side. The X-ray beam is coming through the back of the mirror. We can't put the light in the radiation beam, or we'd have a light artifact in every X-ray we create, right? So it's got to be off to the side. So it's got to be, the mirror has to be at a perfect 45-degree angle to the radiation field, and also to the light, so that the light will be reflected at a perfect 90-degree angle. All right, so some of the quality control checks that we have to do are the accuracy of our radiation field compared to our light field. So we'll get deeper into this next semester, but sometimes because of rough handling, that mirror can kind of slip a little bit. So if it's not at 45 degrees, it's more horizontal. What that's going to do is it's going to misrepresent your radiation field. Your radiation field and your light field should be almost identical. There's a variance there, and again, we'll get into that later. But if it slips, it's going to become more horizontal, which is going to take your radiation field and it's going to make it go that way. I'm sorry, your light field is going to go that way. So you line up to this patient's skull, since we're going through skull work, and they're in the light field, right? But on your image, the entire light field is shifted. So this is what you get. That's a good indication that your light field and your radiation field are misaligned. Okay, so perfect 45-degree angle. The distance from the focus, the focal point on the anode, to the back side of that light has to be exactly the same as to the back side of that mirror, has to be exactly the same as the distance from the light to the mirror. Now, why is that? What spectrum are light and X-rays a part of? Electromagnetic spectrum. So they have similarities in their behaviors. They have differences, but they have similarities. So they're going to diverge at the same rate. So if our light field is way back here and our focal point is here, then you have dissimilarity between those two things, right? So same distance, perfect 45-degree angle, and then of course we've got the increase in inherent filtration as well. All right, so we just talked about all those. There's your collimator housing. This is kind of busy with all the X-rays coming off of it, but that's your multi-leaf collimator to limit. I love how they put the one off-focus radiation bounces off of the nut that holds the anode onto the anode stem, or the disc onto the anode stem. But that's what that's supposed to represent, and that's what that is supposed to block. So is it going to block some primary radiation that's coming off of the anode? Yeah, it is, but really these shutters down here are what we use to limit the radiation field. Extension cylinder, cone, that's just a static cylinder. These things right here, I can tell you from experience, if you're ever working anywhere where they routinely use these, and you probably will not, but if you do, make sure the thumb screw is screwed down before you grab the base part of the cylinder and turn it over, because you will get a blood blister whenever this slides down and pinches your finger. They're heavy, not prohibitively heavy, but they're heavy enough that they'll get you, they'll bite you. So we talked about that, all of this. So the cylinder reduces penumbra. We described all that. Diaphragm, it says single sheet of lead, and that may or may not entirely be true, depending on how much they want to block and how thick the lead sheet is. It's generally true, but it may not necessarily be true. But the description is valid. That is lead mounted on aluminum with a hole in it.
It's LE80, right? Lead?
Yeah. It's a LED mounted. It's a little bitty light bulb.
I just wanted to make sure we were talking about lead.
Oh, I can't
That's
monitor.
something
I
different.
can't edit it on here. I've got it open in my office. Yes, lead. LEAD. Thank you.
Oh,
Aluminum. Okay, so when I was in the program, the lady who taught imaging and positioning, a few other things, she could not say aluminum to save her life. She called it alunium.
Oh.
Alunium, yeah. And I don't know how long it took me not to hear alunium every time I looked at aluminum. But yeah, anyway. Okay, so collimators. You'll see questions about collimators, your variable aperture diaphragm. And remember that there are two sets of collimators, and that is not two sets of shutters, right? You have a set of shutters, and that set of shutters has two sets that go, they're altogether 4 shutters. That's 2 sets of collimators, one on top to limit that off-focus radiation, and one on bottom to limit field size, right? So 2 things to remember about your collimation is that one is that you should collimate to the part, the anatomy, right? And that's what I've been preaching on. The other thing is that it should never exceed the size of the image receptor, right? So if you happen to be, using an image receptor, this is a grid. This is just a wore out grid. This thing is just destroyed. And you can tell how old it is because it's referring to the blocker, it's referring to the film. It's got some years on it. It's got some stories, right? But anyway, we'll talk about this. I wanted to go ahead and bring it down. But if your image receptor, if you find yourself working in an institution where the image receptor is this size, maybe a pediatric little place, and then you get one of these baby Huey kids that comes in, you're doing a chest x-ray on them. Are they gonna fit? The answer is no, they're not. They're not gonna fit, right? But what if I increase my radiation field? It's still not gonna fit. The only thing that's gonna be represented on here is, the anatomy that's no bigger than the image receptor. So no larger ever than the image receptor. That's just dosed to the patient. That's unethical. And secondly, you want to limit your radiation field just to the anatomy. If you include additional anatomy, that needs to be at the discretion of the hospital protocol or the doctor, and not just because you're not doing your job, right? That's unethical. So, all right, so better look at the multi-leaf collimator up on top. And can you see that little black stripe right there? That's probably the tab that would hold. I can't tell for sure because I can't see, kind of the inside of it. But that would probably be on that machine, the tab that you could put things into that would hold things like your extension cones and things like that. Okay. All right. So, what is our time? We're right at an hour. All right, so why don't we do that and start again just directly into it, but why don't we pull up there.